You will read over the last few years trials on various new drugs, primarily for the core symptoms. So oxytocin is a naturally occurring hormone that is involved in the milk letdown reflex, gives you that warm, fuzzy feeling and makes you want to be with people. So it has to be administered intranasally, and there are some interesting smallish trials suggesting that in some older individuals it can be effective. Memantine is a drug that is an antagonist to MMDA receptors, so it's decreasing the glutamate system, and D-cyclosporin is a drug used in tuberculosis but has a similar sort of action. And D-cyclosporin and bumetanide are what we sort of call crossover drugs. So they're drugs that were developed for one condition and found to be useful in another. So bumetanide is a diuretic, but increases GABA levels in the brain. So there have been some small-scale studies. So these are areas where you need to keep your eyes open. Now, you all know there's considerable heterogeneity within the autism spectrum. So when thinking about first diagnosis of a comorbid disorder and secondly how to treat it, it's a good idea to take a family history, because these things run in families. Depression runs in families, anxiety runs in families, and if bipolar disorder runs in families and you have a depressed individual with ASD, you want to be very cautious when you start SSRIs. Another issue is that we have no idea how much individuals with intellectual difficulties, and particularly those without any language, are suffering side effects that they have no capacity to report to us. So we need to be particularly vigilant. Compared with ADHD, we have very few practice parameters for the use of medication in ASD. And my advice is always to suspect anxiety. A lot of irritability is actually anxious irritability, not aggressive irritability that has a different cause. And I think overall our aim is the fewest medications at the lowest effective doses. And one striking aspect of the literature reviewing it for this talk was I only found one study that had used a quality of life questionnaire when assessing the impact of medication on children with ASD, which seems a bit sad. So we do need effective drugs for severe self-injury. This is one of the most tragic comorbid associations with ASD. We have very little in the way of effective treatments for this. We do need more effective interventions for pre-pubertal children. It may be that that is an unreachable goal simply because of the differences between children's and adults' brains. But drug companies make their money on the basis of the size of the target population of the drug they're making. And by and large, children tend to follow in adults' footsteps rather than drugs being developed specifically for children. And I think we definitely need drugs that are even more effective for treating anxiety. The SSRIs are good, but seldom can I get someone to what I would call a normal level of anxiety. Most people are still suffering, even if they're being treated with an appropriate medication in an appropriate way. And thank you for letting me have extra time.